AFMC is really known.
That this building will provide ideas
and also make sure
between the office hours.
Welcome to this edition of AFMC TV. I'm Robin Ledbetter. Thank you for joining us. Today, I have Ryan Kelly joining me, and he's in a leadership position for the states of Mississippi, Alabama, and Arkansas Rural Health Associations, and he's also involved with the Mississippi Telehealth Association, among many others. Thank you so much for joining us, Ryan.
Thank you, Robin. I appreciate being here.
Yeah. So you are also on the advisory board for the South Central Telehealth Resource Center, which is part of the larger National Telehealth Resource Center. Tell me about the resource centers and what their future looks like.
Sure. So these resource centers are all across the country into different divisions divided into different states. So you mentioned the South Central Telehealth Resource Center, which I would imagine many of the viewers here are a part of. These resource centers are focused on growing and expanding telehealth education to assist in understanding policies within these states and providing some examples of what telehealth can do. And to an extent, kind of almost being on the cutting edge of telehealth research and innovation. So we've really enjoyed our partnership with the South Central Telehealth Resource Center. I've also been involved in the Southeast Telehealth Resource Center and have spoken to some all across the country, and they are very valuable resources for us.
So the public health emergency opened up telehealth services to providers who had not adopted telemedicine, often due to lower reimbursements. So with the public health emergency now ending, what does the future look like?
It's a good question, and it's definitely one of the more common questions I get is with that PHE ending, everyone's afraid telehealth is going to go away. And what I remind them is telehealth had existed well before the pandemic. It's just that the extreme increase in utilization is why it's really become on people's radars, which I always wondered, pre-pandemic, how are we going to get telehealth into the hands of others who have not experienced it? And we saw this just rapid increase in the utilization of telehealth. CMS alone had a near 300, or actually more than 300% increase, 300 times increase in the amount of telehealth utilization. It's almost a number that I would be making up if it weren't true. And so we knew that in the pandemic, that number would decrease. Or after the pandemic, it would decrease, and it did. It's an unsustainable number, but we're still 38 times the utilization of telehealth now than we were pre-pandemic. And so to answer your question with the public health emergency ending, there are some things that we're watching, particularly on the national scene. Most of our states, particularly those contiguous to Arkansas, and a lot of our southeastern states have extended permanently their pre-pandemic or their pandemic-related provisions for telehealth, especially with divisions of Medicaid. There are some things with telehealth during the pandemic that are not extended or that are a little more closely governed. Some states with the provider extensions that they've had, allowing providers that were not licensed in the state or granting some special access have decreased, as well as the audio only aspect is not necessarily as widely accepted as it was. And then one big thing from the federal side is the safety and security of the platforms from a HIPAA compliance standpoint. That has gone back to pre-pandemic recommendations. It was never recommended that anyone use a non-HIPAA compliant platform, but again, emergency, you do what you got to do. But the entire time we suggested to people a wide variety of very cost-effective platforms that could be used that are HIPAA compliant, and we think that is a very important thing that people take on right now, especially in the age of major cybersecurity issues. But from a sake of reimbursement, we're in a very good position right now for most of our states. The only thing we are watching is that the federal government did, as I like to say, kick the can down the road a little bit from the rural health clinics and the federally qualified health centers being able to be reimbursed for telehealth. That was kicked back until 2024. That is something we are actively lobbying for on the federal side right now to make sure that that is handled. And then once that is written into federal code, then that is really the only major concern I personally have from a reimbursement standpoint. And then from here, it's just a matter of how we can make it grow and progress.
So what needs to happen to ensure telehealth visits remain a viable option for physicians and patients?
Yeah. So let me go back to that federal legislation that I mentioned. That is one that is very important for a lot of our rural facilities in particular, because there's just special carve-outs that did not allow telehealth to take place for rural entities during the public health emergency that was granted. There's really no opposition to it. It's just a matter of how do we get that into the right legislative vehicle, as they call it, a bill, to get it passed. I will say if there was an obstacle, the Office of Management and Budget, the OMB, is grading it as being a cost to the federal government, to the taxpayer. I completely disagree with that analogy, as many do, because how telehealth has been seen time and time again to be a cost saver as you're focusing on wellness and prevention and primary care, and you're offsetting the cost of secondary and specialty care, not to mention emergency care. So we're seeing it as a major cost saver. I disagree with the OMB's budget on that, but that is really the only negative that is there. There's really no legislator on any side of the aisle that is against it. We're just trying to find the right way to get it passed. So that's a big one. Now, for the other is just the basic adoption aspect. I rarely find someone who is opposed to the idea of telehealth nowadays. Almost everyone has used it. They find it to be very beneficial for patients, usually pretty easy for them. They like the fact that the recording can be stored in their electronic medical record. They can refer back to it. There's all sorts of artificial intelligence that can be used for transcription and making notes. It's got a lot of benefits. But now that patients are back in person, what I'm finding, especially for smaller facilities, is their providers, physicians and nurses alike, are having trouble finding a way to treat the in-person patients that have gone back to, sick visits, going to the waiting room, waiting for an appointment, going in, and using the telehealth capability of people coming on and requesting a visit and handling both at the same time. It's just more of a logistical administrative issue. And so many of them are working through it. I've seen a lot of interesting setups where they're literally scheduling a telehealth visit just like an in-person visit. I think that's probably a best practice right now. But for those that are not sure exactly how to do it, that seems to be the one obstacle for them. Not that they don't see value in it, but they just can't quite figure out how to do it in their with their setup right now.
So do you think technology and innovation can help bring down costs?
I do. And so we do see telehealth being a cost saver. Assuming telehealth is reimbursed at the same rate as an in-person visit, which is not the same in all of our states, but many of them it is, then you're not costing more for that visit. But by granting greater access, that patient may be receiving care where they wouldn't have before. And so let's just take diabetes as one of many examples. Someone that's on a lifelong treatment of insulin is extremely expensive for Medicaid, for Blue Cross, for any commercial insurance, not to mention detrimental for that patient. So if you take it from just the healthcare perspective, not even getting into the economic development perspective, just the healthcare perspective alone, someone on diabetes costs the federal government or the taxpayer which is one and the same, or commercial insurance, somewhere around 25 to 30 times more than the average patient does with the treatment, with the number of visits they have, with the insulin. Now, obviously, this gets into some social determinants of health with food deserts and health education, health literacy. But just from the treatment alone, if we can catch someone who's pre-diabetic and go ahead and put them on some insulin production medication to reduce their A1C and to keep them from going into full diabetes, we can save them and the taxpayer literally hundreds of thousands or more dollars over a lifetime, which is huge. And so that is a cost saving. Now, if we go into the other side of this, which is integrating other software types, artificial intelligence, for instance, and now we're predicting health outcomes and empowering physicians or nurses to be better educated into what might be something to look at down the road. And I'm not even going to get into genetic testing because I'm a little leery, honestly, on the genetic testing side, but there is value in theory on the genetic testing, assuming that this information is not stolen and used against us, which again, I'm a little on the fence on. But all of the technology we have right now, if used appropriately, can absolutely empower providers to care for their patients in ways we've never been able to do before, which again, a healthy patient is what we want. Not only is that the most cost-effective thing, but it's the best thing for our society. So yeah, absolutely. Telehealth if used correctly and appropriately, can absolutely reduce the overall cost in our healthcare system and can make our healthcare system better than we've ever imagined it to be.
So last question, the significant expansion of telehealth disproportionately increased access to care in urban communities, but what does that look like for rural communities, especially or specifically Arkansas?
So that was one of my big surprises when I started looking at data post-pandemic, is that the urban aspects of telehealth were greater than the rural. And I really would not have expected that. And it's a little bit of a bummer to me. I'm not going to lie. I thought that telehealth would have grown faster in rural areas. But I do get it. You've got greater broadband access, generally speaking, in our urban areas. You also have greater concentrations of people in our urban areas. So despite the fact that transportation is less of an issue in urban, not a non-issue, but less of an issue, you still have more uptake of telehealth in urban areas than rural. And there's probably a whole laundry list of reasons why, not just one, probably many. But I do stand beside the fact that telehealth is a huge equalizer for the sake of rural healthcare. Now, we don't want to sacrifice in-person care for telehealth. We want to use telehealth as an augment to in-person care. And hopefully, and our goal with telehealth is eventually for there not to be a distinguishing factor between in-person and telehealth. It's just all healthcare, and you pick what modality is best suited for the patient and for the provider at that time. So we don't want it to be looking like something different. We just want it to be something that is a tool in the tool belt for providers to have access to their patients. And with the technology we have, the peripherals that are becoming more and more available, you can do dermatological visits. You can have a camera that can look down your throat and look in your ears, and peripherals that can take your blood pressure and heart rate and temperature right from your home, that are very cost effective. And so I'm really interested to see how that progresses with the peripheral side that can just plug right into the bottom of an iPhone, that would be able to do all of these multifaceted things. They exist now. It's just a matter of how do we get that in the hands of the consumer. And I think that's probably a big aspect of where we're going. Some would say augmented reality. I do not like augmented reality, the VR goggles. I think that's actually, from a mental health standpoint, very dangerous. But I do like the technology that builds into the current technology that can grow access for us in the real world, which is where we exist now.
Well, thank you so much. So interesting and informative. I've learned a lot, and I appreciate you making the time to talk to us today. And I have no doubt that our audience also will take away some really great information that will be beneficial to anyone who watches. Ryan, thank you so much, and have a great day. And for AFMC TV, I'm Robin Ledbetter. Thank you for watching.